Today we're meeting to discuss how to improve outcomes for frail older people. We're going to focus initially upon the term in terms of a medical definition, but also its wider use, the benefits to society, how it might be avoided or delayed, the identification and its measurement and by whom in the community, and the contribution of different professionals to support people with frailty to continue living at home if they so wish. Importantly, we'll also look at the place of hospitals within the care system. And lastly, improving nutrition of frail older people.
It's actually a specific syndrome that we refer to when we're talking about frailty, which is something that doesn't affect all older people, so it's not an inevitable consequence of ageing. It's associated with a sort of diminution in homeostatic reserves, so that something that a younger person would shrug off and make an older person destabilise. So for example, a minor infection that if one of us around the table got, we'd feel a bit miserable for a day or two, but then we'd be absolutely fine. In an older person who was frail might lead to them becoming delirious or having a fall or going off their legs.
So many patients that I come across don't wish to perceive themselves as frail. It has a different connotation to how we want to utilise that label in terms of supporting them. And actually I find it often disengages them or acts as a barrier if you bring up the frailty word in any conversation.
I think it is very much as well using the term living with frailty. How can you positively spin that to help people who have got who are frail, to how they best live with it, how they best, the positive, how that enables them to do what they want to be able to do.
When you identify a lot of these issues, there are no solutions. The system is not set up to deliver things that would enable you to lead a more proactive life. So for example, even things like going to the GP, if there's no transport and you can't get out, it's very difficult to do.
We haven't really succeeded in getting everyone to identify frailty, because all of those opportunities should be taken, whether it's people interacting with volunteers or family or health professionals or social care professionals. We should all be looking at when there's a change in somebody, should we be thinking about frailty and thinking about helping them to access sort of health and social care coordinators or social prescribing or whatever is the solution for getting them more engaged in their community and overcoming some of the issues that they have.
Every conversation that an individual has with a person who is frail, whoever that person is, whether they come from a health or social care setting, whether it be a volunteer, whether it be someone from a charity, is a conversation that can actually have meaning to that individual and draw out the issues that are important to them. And what's important to you or me is going to be very different to what's important to that frail person, and that will then help them to understand where they need to seek support, and whether that be in primary care, whether it be whatever it is. It's that conversation and people understanding that they have a real opportunity to support individuals in that way.
It's always great when you see sort of example of good care planning that then brings in all of those different parts, and actually making sure that the warfarin clinic is speaking to the rheumatologist, is speaking to the diabetes consultant, speaking to the geriatrician, who's keeping the GP informed, and actually there is huge amounts of people involved in one individual person's care. So ensuring that there is good quality care planning then.
There was some more practical and physical interventions, like ensuring they have a flu vaccine, and then there are mental health or mental health interventions around the IAPT and long-term condition, but we never, and there are physical health checks, but they're in primary secondary care, they're not in the home, you're not looking at the whole person, you're not looking at their surroundings, and I think if you did, you could minimise that risk.
I just want to share an example of good practice of what can be done to address frailty in hospitals, of what's actually happening at Airedale Hospital where I'm based. We have a frail elderly pathway team. They're based in emergency department and medical admissions unit, the longer frail people stay in ED, the worse are their outcomes. So they're linked with the emergency department. As soon as frailty is identified, then they come under the care of this team, who move them through the system as quickly as possible and get them home as quickly as possible, but getting really good care in place, ready for when they go home. We've looked at the readmission rates, the readmission people 6 months after are not getting readmitted, or if they are readmitted, it's something that couldn't have been prevented, and the lengths of stay in hospital are much smaller. So better for the patient, better for hospital flow, better for the NHS, better for social services, so everyone's a winner.
We need to ensure that the individual doesn't feel that the label frailty means a loss of their independence.
And it's not one healthcare professional's responsibility to manage frailty. Frailty is a continuum, and clearly the earlier we can identify it and start managing, the better. So every point of contact from healthcare to voluntary sector is important.